Okay. Today we will continue our discussion on acute coronary syndrome, and the one remaining topic is unstable angina. Uh, we discussed other subtypes of acute coronary syndrome in the previous session, and today we will discuss unstable angina, and after that we will talk about chronic coronary syndrome, which previously was called stable angina. So, unstable angina is a non-ST elevation acute coronary syndrome, a part of the non-ST elevation acute coronary syndrome. It has the sign and symptoms of cardiac ischemia, like just discomfort, diaphoresis, the sometimes nausea, vomiting, and other symptoms of cardiac ischemia, but the, the patient doesn't have ST segment elevation. And also, another point is that the troponin is negative because there is no myocyte necrosis. Because of that, the troponin level is normal. Uh, And this is the main difference between a non-stay elevated MI and unstable angina, because a non-stay elevated MI, it's myocardial infarction. There is necrosis of the myocytes, but in unstable angina, uh, there is no necrosis of the myocyte. Still, no necrosis. It can progress if left untreated. But when we say unstable angina, it means that the necrosis has not occurred yet. Pathophysiology is similar to other acute coronary syndrome subtypes. It's due to plaque rupture or erosion, but ischemia is transient and occlusion is incomplete. Coronary artery is not occluded just completely. And because of that, there is reversible myocardial ischemia, and necrosis has not established yet. And because of that, because when there is myocardial necrosis, then the troponin is released. And because of that, and because there is no necrosis, troponin level is not raised. Risk factors are similar to acute coronary syndrome. Most common risk factor is hypertension, but the most dangerous is diabetes and also dyslipidemia, smoking, prior coronary artery disease, myocardial infarction, cardiac procedures like PCI or CABG, and stimulant use like cocaine. They can all cause unstable angina. And in the questions, the trap is that the patient has the symptoms, but not the ECG changes, and the troponin is negative. And because of that, sometimes the candidate will be confused and may not choose the correct option. The signs and symptoms are just new or worsening wrist chest discomfort. In acute coronary syndrome, the chest discomfort is while the patient is on rest. It's the difference between unstable angina or acute coronary syndrome and chronic coronary syndrome is that the pain in acute coronary syndrome spectrum, the pain is while at rest. The patient is at rest, but still has chest pain. But in chronic coronary syndrome, the patient has pain while exertion, but the pain is relieved with rest. This is the main difference between acute coronary syndrome and chronic coronary syndrome. And in unstable angina, the patient has chest pain while at rest, but ECG changes are not present, especially there is no ST elevation, and there is no troponin level rise in the patient. In physical examination, it can be normal, or we can see signs of ischemia, such as diaphoresis, like hemodynamic changes, nausea and vomiting. And the key point is that we cannot diagnose unstable angina with a single test or a single physical exam. It needs to be under monitoring, and uh, after a few tests, we can establish that it's an unstable angina, or and then non-ST elevated MI or ST elevated MI. Dr. Sarah, you wanted to ask something?
Sorry, doctor. Would you please repeat again? Repeat difference between acute coronary syndrome and chronic coronary syndrome. I
Yeah,
was distracted a little bit. Sorry.
sure,
Thank
sure,
you.
sure. Why not? So the main difference between acute coronary syndrome and chronic coronary syndrome is the pain pattern. Chest pain in acute coronary syndrome is at rest. The patient is at rest, but the patient has pain. In chronic coronary syndrome, the patient has pain while exertion. For example, the patient may go upslope, or maybe go do some heavy exercise like shoveling, or other exercises, and the patient will have pain while exercise or while exertion, and then when the patient rests, the pain disappears. This is the main difference in acute coronary syndrome and chronic coronary syndrome.
Thank you, doctor.
So uh, and the diagnosis of unstable angina cannot be done just at once. Like ST elevated MI, we see the patient with symptoms. We take an ECG and we see ST elevation in certain leads, and then we diagnose the patient with ST elevated MI and send the patient for revascularization. But in unstable angina, we cannot do that, because the ECG changes are just, maybe there is no ECG change, or maybe a non-specific change, and the troponin level is normal. And because of that, we have to perform the serial ECG, serial troponins, to establish a diagnosis. Yes, Dr. Robert?
Hello, sir. You mentioned that chronic uh, uh, coronary syndrome, that at rest,
Yeah.
the pain will disappear. So does it mean
Yes.
that it has the same kind of situation with stable angina?
Well, we will come to chronic coronary syndrome after after unstable angina is done. We will discuss it tonight. So, yeah, as I mentioned previously, it was called stable angina previously, but now because it's a syndrome, it's a spectrum of diseases. It's called chronic coronary syndrome. So we will discuss it tonight.
All right, thank you.
Yeah. Okay. So the diagnostic approach for unstable angina is because the patient comes with chest pain, and the patient will come in emergency room. The first thing is that we have to rule out ST-elevated MI. Because of that, we have to get a 12 lead ECG within 10 minutes. It means as soon as possible. And we will put the patient under continuous monitoring. And ECG can be normal, can be ST depression, can be T inversion. And it's mostly transient because the occlusion is transient, the occlusion is not complete. The ECG changes will also will not be permanent, they will be transient. If we see any T inversion like this or ST depression like this with downsloping. Downsloping means from left to right, it goes from up to down, downsloping. And we need to confirm if it's unstable angina or non-ST elevated MI or ST elevated MI. We have to repeat the ECG and troponin levels. And when we see that the ECG changes are transient in serial ECG tests, and also the troponin doesn't rise, so we can establish the diagnosis of uh, uh, unstable angina. And the differential diagnosis is with other types of acute coronary syndrome like ST elevated and non-ST elevated MI. With aortic dissection, chest pain, pulmonary embolism, pericarditis, reflux, musculoskeletal pain. And the main thing in diagnosis of unstable angina is serial ECGs and troponins. And we see that the troponin level will not rise, and the ECG will become normal after the patient is pain-free because it's transient. But if the troponin level rises, then it's not unstable angina. Then it's myocardial infarction, and if the ECG is still with T inversion or ST depression, and the troponin rises, then it's non-ST elevated MI. But if the ECG changes to ST elevation and the troponin level rises, then it means that it's complicated to ST elevated MI. The management of unstable angina is the first or initial acute management is the same as acute coronary syndrome, and we have to rule out acute coronary syndrome. We start with EBCs, we do the continuous monitoring, establish an IV access, we have to take a focused history and the ECG within 10 minutes. Aspirin 162 milligrams if there is no contraindication, nitroglycerin sublingual. If no contraindication, and the contraindications we discussed in the previous session, that it was hypotension, phosphodiesterase 5 inhibitor use, and also inferior wall infarction. Also, if the patient is hypoxemic, means If the patient's oxygen saturation is less than 90, then we have to give the patient oxygen as well. This is the acute management, first line management when the patient comes to the emergency room. But the definitive the treatment, it depends on the risk stratification. The patient should be admitted. We admit the patient, but we should risk stratify the patient. Is the patient low risk, medium risk, or high risk? And based on the risk stratification, we do the management. Treatment can be escalated. We can in low risk patient, non-invasive therapy or late invasive therapy can be done, and in medium or high risk pharmacotherapy plus revascularization. It depends on how the risk stratification of the patient will come out. Initial medical therapy or the pharmacotherapy is we do dual antiplatelet therapy, aspirin, clopidogrel, anticoagulation like unfractionated or ultrafractionated heparin. We can use nitroglycerin if there is no contraindication. Beta blockers to lower the heart rate and also lower the oxygen demand of the myocardium, and oxygen if the patient is hypoxemic. Lipid management, we should initiate statins early because it will affect the long-term risk reduction. And for long-term, the patient needs antiplatelet indefinitely, beta blockers, and risk factor modification. For example, if the patient has hyperlipidemia, we have to control it. Hypertension, control it. Smoking cessation is a very important risk factor modification. And also a structured follow-up and medication adherence are very important for long-term to reduce long-term mortality. So this is how we do the risk stratification for these patients. Yes, Dr. Sarah?
Sorry, doctor. In allergy to aspirin, in unstable angina, we should use clopidogrel, or according to the previous page, I mean, the previous slide, or ticagrelor. I mean that which of them should be our priority?
They are the same family of drugs, and it depends on the doctor. It depends on the protocol of the hospital. Some hospitals use this one. Some hospitals use this one. And in the question, they will not give you both as two options to choose one from these. They will give you
In first
either
session, I think we
this
have
or this.
this question. In first session, I can remember this question, and because I think they told us ticagrelor, but because here you mentioned
It-
that
it's-
ticagrelor as an added, yeah, okay.
yeah, it's the same.
Okay.
Yeah, we give aspirin and we add either this one or this one. It's dual anticoagulation for the first, but for the long term, we just gave one of them. After 1 year, continuously we will give one. uh, especially if the patient is not on. Uh, sometimes they continue, but the evidence shows that monotherapy for long term is enough, and dual therapy is not needed for the long term. Yes, Dr. Chibuzur?
Yes. So, is a follow-on to the question that was asked last between clopidogrel and ticagrelor. If we see both of them in the option, which are we taking? Then the second question is, I saw this add GP, I think this glycoprotein 2B3A. Are we headed towards PCI, or is this a preparation to do PCI, or is this for, unstable angina?
This is the medical therapy,
Okay.
yeah. But for how to decide which therapy, we have to risk stratify the patient. And as I said, you will not see in the question, you will not see these two to choose
Okay.
between, because we when we sit in the MCCQ1, they expect us to be just general doctors who've just graduated from the university. We are not specialists, so they will not give us specialist questions for example, for a hepatobiliary surgeon or for a cardiologist. If you're a cardiologist and you want to go and sit in a specialist cardiologist exam, then you will not see this kind of question, or these questions will be very limited in those settings, and they will focus more on specialist aspects of the any topic. But in MCCK1, you will not see specialist or subspecialist questions. They will give you very clear picture, clear options. They will not just make you decide like a specialist cardiologist. So to decide how to manage these patients, we have to risk stratify them. Low risk patients means normal serial ECGs, no ongoing pain. So we can discharge the patient with follow-up of less than 72 hours with this medicine. We give the patient medicine, and then we can discharge the patient, and then we have to follow up within 72 hours. If there is intermediate risk, which means ischemic symptoms without high risk features, we have to admit the patient, and then when the patient is stabilized, we do an elective angiography for the patient. If there is high risk, which means persistent stage depression, ongoing ischemic pain, and hemodynamic instability, then the troponins remain negative, we send the patient for angiography and revascularization. Because despite the patient has unstable angina by definition, but as the risk is very high, we will send the patient for angiography and revascularization. This is how we risk stratify the patient for management. We will not be. This is the risk stratification is to give the patient the treatment it requires, not over treatment, not under treatment. And because of that, we stratify each patient, and according to the risk stratification, we have to consider the proper management plan for that patient. And this is how we risk stratify the patients. And when there is left main artery or three vessel disease, then CABG can be considered for a patient. When there is no ST segment elevation and acute myocardial infarction, you should not go for intravenous thrombolytic therapy. So in this table, we see the summary of risk stratification. This is the low risk, intermediate risk, and high risk. These are the features, and these are the management approach. What we do with this with the patient with this level of risk. Complications and prognosis of unstable angina. So it can progress to non-ST elevated MI or ST elevated MI. As we said before, it's not myocardial infarction yet. But if the patient is not treated on time, it can progress to an MI, which is myocardial necrosis. It can cause arrhythmias, it can cause heart failure or sudden deterioration. The red flags for any acute coronary syndrome is recurrent pain, hemodynamic instability, dynamic ECG changes, which means the ECG changes will progress towards ischemia. For example, if it's at the first, it may be normal, then it can change to ST elevation or ST depression, T inversion. And if they remain, they show that the heart muscle is under stress of ischemia. If we have these red flags, we have to escalate. We have to escalate to invasive evaluations like for angiography. And if the patient's condition is worsened, then we can send the patient for PCI or other invasive procedures. And for long-term follow-up, it's the same as the other acute coronary syndrome subtypes. The patient needs dual antiplatelet therapy, beta blockers, EC inhibitors, when indicated, statin therapy, and cardiac rehabilitation. These are high-yield testing points in unstable angina. A classic question would be a patient with coronary artery disease risk factors, and the patient has chest pain, an ischemic chest pain at rest, or the patient had this angina and it becomes worse, but there is no ECG changes, no persistent ST elevation, and troponin level are normal. This is the classic type of a patient with unstable angina. And these patients are not safe to discharge. We have to admit these patients. And common answer traps, we cannot call it ANSTMI because of troponin level. When the troponin level is normal, it's not MI. It's unstable angina. And because ECG or troponin is normal at the first presentation, we should not discharge the patient. We have to do serial ECG and troponin. And fibrinolysis is not for unstable angina. It's for ST elevated. Next best decision points, if unstable angina is suspected, what do we do? The next step would be admit, continuously monitor, serial ECG and troponin, and start ACS therapy. If high-risk patient or a patient, at first the patient is not high risk, but the patient is deteriorating, then we have to involve cardiology and consider transfer to a PCI center. So unstable angina is acute coronary syndrome, but without troponin elevation. It's not a benign condition, and it requires admission. It requires urgent management, because otherwise the patient will progress to non-ST elevated MI or ST elevated MI. So this was the review of unstable angina. Now we will discuss chronic coronary syndrome. So it's a clinical syndrome, and it's stable or intermittently progressive coronary artery disease. And it can cause myocardial ischemia. Chronic coronary syndrome was previously called stable angina. So now it encompasses stable exertional angina, silent myocardial ischemia, vasospastic angina, microvascular angina, previous MI with stable symptoms, and newly diagnosed coronary artery disease without acute coronary syndrome. So we see that it's a spectrum of conditions. It's not an emergency case unless the symptoms become unstable. Three main pathophysiology points. First, it's a fixed obstructive atherosclerosis. Most common pathophysiology is that the coronary arteries are there is a stenosis of coronary artery, and it's a fixed stenosis. It doesn't change. And how it develops through endothelial injury. Because of endothelial injury, there is LDL deposition, and then when inflammation occurs on top of this, then fibrous plaque is formed, and then if it occludes 70% of the coronary artery, then it causes a reduced coronary blood flow, and because of that, the patient will feel anginal pain or chest pain during exertion, because the oxygen the blood flow cannot fulfill the oxygen demand of the myocardium during exertion. But when the patient is at rest, the blood flow is fairly enough for the cardiac muscle, and because of that, the patient doesn't feel any pain, and there is no ischemic pain. But when the patient is exerting, or the patient does exercise, then because the heart rate increases and the heart oxygen demand increases, and there is a fixed the blood flow to the heart is limited. It's a fixed stenosis, and the blood flow to the heart cannot increase. But the oxygen demand increases, and because of that discrepancy, then the patient will feel ischemic pain because the heart muscle becomes ischemic. Another pathophysiology is coronary microvascular dysfunction. In this condition, the coronary artery is normal. It appears normal. It's not stenotic. It's not, and there is no atherosclerotic plaque in it. But the small arteries within the cardiac muscle, they are dysfunctioning, and because of that, the blood flow to the heart muscle is reduced, and because of that, the patient will feel ischemic pain while exertion. The microvascular dysfunction is the dysfunction of small arteries within the heart muscle, but in the atherosclerosis is in the coronary artery. It's not in small arteries. It's in the coronary artery, the main artery that supplies blood to the heart muscle. And another pathophysiology is vasospastic. The coronary artery is normal. There is no atherosclerotic plaque or sclerosis, but the coronary artery smooth muscle spasms, and because of that, the diameter of the coronary artery becomes small, and the blood flow to the heart muscle becomes limited, and because of that, the patient will feel ischemic pain. And that vasospastic disease, coronary artery disease, is called Prince-Metal angina. Anyway, in any pathophysiology, the main mechanism is myocardial oxygen demand exceeds oxygen supply. Because the blood flow is limited, the oxygen supply is limited, but the myocardial oxygen demand is high. And because of this discrepancy, the heart muscle or cardiac muscle becomes ischemic. Yes, Dr. Sarah?
I'm sorry, doctor, we said that Prince Metal is during rest. Am I right? And
No,
chronic, it is in contrast with the
it's
definition of chronic coronary syndrome.
yeah. Prince metal is spasm of the coronary artery.
Yeah,
A
I know,
spasm
but
of the yeah.
it's during a rest. Am I
Yes,
right? In the
the
in
patient,
the
it can
morning.
be, yeah, it can be during the rest, it can be during exertion,
Okay, so
but
during exertion can.
the main thing is that it's transient.
Mhm.
It's not like acute coronary syndrome that causes necrosis of the cardiac muscle. It's transient, but it causes pain. It causes chest pain. But this chest pain is transient. It's not more than 20 minutes. And because of that, because the patient feels it for a long time, then it's called, this is part of chronic coronary syndrome. The risk factors, we have traditional risk factors and new risk factors that have become more common. Traditional risk factors are smoking, diabetes, hypertension, LDL elevation, and chronic kidney disease and uh, endogenous cardiovascular disparities like sedentary lifestyle, they are emerging. Epidemiology, the risk increases with age. Male sex is more prone to chronic coronary syndrome, diabetes, CKD, smoking. These are the this is seen. Chronic coronary syndrome is seen in this category of patients more than anyone and the other population. And this is the major cause of hospitalization, disability, and cardiovascular mortality among population. So the clinical features of chronic coronary syndrome are one are typical stable angina signs and symptoms, and there are atypical symptoms and also silent ischemia. In typical, there is a retrosternal pressure or pain, and it occurs, you see that it occurs while exertion, like walking uphill, climbing stairs, emotional stress, cold weather, heavy meals. It improves with rest and nitroglycerin because it's a vasodilator. Usually it's less than 10 minutes. Atypical symptoms can be seen in women, in older adults, and in diabetic patients. The symptoms can be dyspnea, can be fatigue, can be epigastric discomfort, can be jaw pain, can be shoulder discomfort. They are atypical. We do not see a typical chest pain in a patient, but when we see this population, especially diabetics and older adults, especially if they are female, then we should consider chronic coronary syndrome when the patient has these symptoms. And we have to rule out chronic coronary syndrome. And silent ischemia is common in diabetics. The patient doesn't have chest pain, but the patient has ischemia. Because in diabetics, we know that because of neuropathy, sometimes the patient pain threshold becomes very high. The physical examination can be normal. The patient presents, but we will not find anything abnormal. But we can find hypertension in patients. The patient can have obesity, peripheral vascular disease, carotid bruit, xanthelasma, like because of high hyperlipidemia, chronic hyperlipidemia. And there can be signs of previous MI, like uh, fourth heart sound is four, heart failure or mitral regurgitation, which are the sign of previous MI. It's not new. It shows that the patient may have had myocardial infarction in the past. So diagnostic approach for chronic coronary syndrome is first we have to rule out acute coronary syndrome. When the patient comes, we have to ask, does the patient have pain at rest? It's the most important question to be asked. Is it new or worsening? Is it more than 20 minutes? is the patient has hemodynamic instability? These questions should be answered. And if there is yes, it's not chronic coronary syndrome. It has developed acute coronary syndrome, and the patient should be treated as acute coronary syndrome. But if the patient doesn't have these conditions, the initial workup would be history and physical examination and ECG, troponin levels. If ACs cannot be excluded, we should not give troponin to every patient. If we cannot exclude acute coronary syndrome, we can ask for troponin level as well. The other laboratory tests that should be done for the patient, and they are done to rule out or diagnose the risk factors, the CBC, creatinine, electrolytes, HbA1c, lipid profile. These are the tests that we should do to see if the patient has a risk factor. Resting ECG can show normal, can be normal, can show left ventricular hypertrophy, can show old infarction like Q waves, or can show non-specific STUT abnormalities. So normal ECG doesn't exclude chronic coronary syndrome because it's not diagnostic when the patient is at rest and the patient doesn't have any pain. So choosing the appropriate test for these patients it depends on the pre-test probability, which depend on factors like age and age, obesity, hypertension, hyperlipidemia, and things like that. We will see the next slide. And based on that pre-test probability or risk stratification, we can give the patient exercise stress ECG or coronary angiography or CT angiography. It depends on pre-test probability. And the pre-test probability is calculated by gender, age, chest pain, diabetes, hypertension, dyslipidemia, family history of premature coronary artery disease, and obesity. So this is how we see the imaging selection by likelihood. So pre-test likelihood, if it's very low, 5 or less than 5%, no further test is required. We treat the risk factors and symptoms. If it's low to moderate, more than 5 to 50%, then CT angiography, coronary CT angiography, which is a non-invasive test, and it will show us the anatomy of the coronary arteries, and it will rule out any obstruction or obstructive disease. If it's moderate to high, then we can recommend functional imaging, like stress echo, like radionuclear tests of the heart muscle. And then they will assess inducible ischemia. The patient is exerting, and then the echo is done under stress, and we will see how is there ischemia during exertion or not. And if the pretest likelihood is very high, the risk is very high, more than 85%, then the patient should go for invasive coronary angiography. And in this test, we will directly see anatomical features of the coronary arteries, and with this procedure, we can do revascularization if required. So this is invasive test. CT angiography is non-invasive. Coronary angiography is invasive because we do the ballooning as well. Yes, Dr. Sarah?
Sorry, doctor, these risks are coming from which tests? I mean that I heard about TIMI, and I think that in unstable angina we use TIMI, but here very low, low to moderate. It was from.
There is a calculator. There is a calculator. You can see the calculator in Medscape as well. And they, each of these factors have a number. Gender, age, chest pain, diabetes, hypertension, dyslipidemia. They say yes, no. Gender, male, female, age, we give the patient the age. Chest pain, yes, no. Diabetes, yes, no. Hypertension, yes, no. Dyslipidemia, yes, no. Family history of premature coronary artery disease, yes, no. Obesity, yes, no. With this, they will calculate the greatest probability, and based on that, we will choose our test. But in MCCQ exam, they will not ask you to calculate that. They may give you this, the greatest likelihood. And based on this, you can choose the recommended initial test. They will not require to calculate that on yourself. There's a calculator. They will you can see that how they will calculate, but this for the exam you will not need that.
Thank
He
you.
will give you this. Diagnostic approach for stable angina or chronic coronary syndrome. So we after we just stratified these things, then we can do stress imaging. And stress imaging shows the functional, it's a functional test of the heart muscle. And stress imaging is done when the patient is unable to exercise. And the baseline ECG is normal. Sometimes the patient cannot do the stress ECG test. And when it's the patient is not able to do that, we will do the stress imaging. It's done with nuclear test of the heart muscle. They will inject, and then they will take the image of the heart. It can be stress echo, it can be perfusion imaging, stress cardiac MI. But if the patient is able to tolerate the stress exercise test, then it's more commonly done than the other test. But if the patient is not able, we will do the other tests like stress echo or myocardial perfusion imaging. And in the stress ECG, we will see this downsloping of the ST segment. When there is ischemia of the heart muscle, especially subendocardial ischemia, we will see this ST depression with downsloping. Coronary CT angiography is non-invasive. We saw in this the pretest likelihood that with which level of risk we choose what kind of test. So coronary CT angiography will show an excellent view of the anatomical features of the heart vessels. But it has a very high sensitivity for coronary artery disease. Coronary angiography is invasive, and it's the gold standard test for chronic coronary artery syndrome. When the patient is high-risk stress test, when the symptoms are persistent, ejection fraction is reduced, left main artery disease is suspected, and if we plan for a PCI or CABG, then this is the test of choice, the gold standard test. Sometimes the patient has symptoms of coronary artery disease, but CT angiography or coronary angiography are normal. Then we suspect the angina with non-obstructive coronary arteries or ischemia with non-obstructive coronary arteries, which means that there is a microvascular dysfunction or a vasospasm. And in these conditions, we do a coronary functional testing like this. Differential diagnosis of the chronic coronary syndrome. We differentiate stable angina with all these conditions. Stable angina is a predictable exertional symptoms. It is relieved by rest, but unstable angina, pain at rest. And symptoms are progressive, and it's acute coronary syndrome. NSTMI, it's resting pain, but the troponins are elevated. ST elevated MI, we discussed before, it's ECG diagnosis, persistent ST elevation. Gastrointestinal regurgitation, mostly after meals, the patient feels the burning pain and substernal pain after meals. If there is costochondritis, then there will be tenderness while palpation. Pulmonary embolism, the patient will have dyspnea, pleuritic pain. If there is pericarditis, the patient will have pleuritic pain, and it's positional. When the patient leans forward, the pain is relieved. In aortic stenosis, there is murmur, there is exertional syncope. And in aortic dissection, there is sudden tearing pain, also difference in right and left arm systolic blood pressure. The management of chronic coronary syndrome, first, if the patient comes in emergency department, an acute management would be ABC. We have to exclude acute coronary syndrome, assess the risk, then we should initiate anti-anginal therapy and begin secondary prevention. Which means that the patient, when comes the patient, we have to see if the patient is stable, and we do the ECG to check to rule out any acute coronary syndrome with history, with physical examination, and we will assess the risks. And then, if when we exclude acute coronary syndrome, then we initiate anti-anginal therapy, and then we can begin the secondary preventions like aspirin and statins and other pharmacological treatments. But the definitive treatment for chronic coronary syndrome is multimodal. It's not one thing. The mainstay is lifestyle modification, which is smoking cessation, exercise, 150 minutes per week, a healthy diet, weight loss, blood pressure control, diabetes optimization. These are the lifestyle modifications that the patient needs to control to prevent any further escalation to acute coronary syndrome. The pharmacotherapy that we can give the patient is, one is symptom relief, which is nitroglycerin sublingual every 5 minutes for maximum 3 doses. If it's not relieved with 3 doses, then we have to think about other causes. And the contraindication to nitroglycerin, we know that it's recent use of phosphodiesterase 5 inhibitors within 24 hours. And if it's the tadalafil, which is long term, even it's for 48 hours. And if the patient has severe hypertension. The first line medication for these patients for long-term therapy is beta blockers, which reduce heart rate, reduce contractility, and reduce oxygen demand. But we do not give beta blockers in severe bradycardia or high-grade AV blocks or acute decompensated heart failure, because it will exacerbate those conditions. And if beta blockers are contraindicated, we can give the patient calcium channel blockers or long-acting nitrates. But calcium channel blockers are the first-line therapy for vasospastic angina, like transmetal angina. They are the first line for that condition. Also, disease-modifying therapy, antiplatelet. We can give the patient aspirin or clopidogrel. Statin to lower the lipid level. ACE inhibitors, especially if patient is diabetic, if the patient has hypertension, chronic kidney disease, and reduced ejection fraction. Also, if the patient is diabetic, GLP-1 receptor antagonist and SGLT2 inhibitors are the proven drugs that will help the patient with cardiovascular disease. Revascularization is uh, for patients with persistent symptoms despite optimal medical therapy, and if they have the suitable anatomy. And CABG, or coronary artery bypass grafting, is for if there is left main disease or is multiple vessel disease or three vessel disease, diabetes with multivessel disease, and reduced ejection fraction with extensive coronary artery disease. These are the indications for open heart surgery. So we manage the patient in steps. Step one is general clinical evaluation of the patient, symptoms, rule out acute coronary syndrome, ECGs, and basic tests. Step two is do further cardiac examination like echocardiography to exclude left ventricular dysfunction and clinical likelihood of obstructive coronary artery disease. Other diagnostic tests like to determine the future risks, and also lifestyle and pharmacological therapy, which is risk factor modification and anti-anginal revascularization for refractory disease. We discharge the patient if the patient is stable, has normal vitals, acute coronary syndrome is ruled out, the patient has a reliable follow-up, and medication are initiated, and the patient understands when to come if there is any red flag. We admit those patients whose diagnosis has not been established. The patient has rest pain. The troponins are abnormal. If the patient has heart failure, if there is any arrhythmia, if there is hemodynamic instability, or high-risk stress findings. In these conditions, we admit the patient. Otherwise, if the patient is stable, we can discharge the patient. Complications, it can progress to acute coronary syndrome. It can progress to MI, heart failure, arrhythmias, sudden cardiac death, and ischemic cardiomyopathy. If pain is at rest, it's increasing in frequency, and the duration is more than 20 minutes, then it's a red flag. If the patient has syncope and hypotension, it's a red flag. If the patient has pulmonary edema, it's a red flag. It means that there is heart failure. If the troponins are elevated, it's red flag. It means it's not chronic coronary syndrome, it's acute coronary syndrome. If the ECG changes are dynamic, they change from one time to another time. For example, in a series, when we get the patient's ECG after 10 minutes, then after 20 minutes, when we see that they change, then this is a red flag. And we have to reassess the patient for acute coronary syndrome. And the long-term follow-up is like other cardiac conditions, like you have to monitor blood pressure, lipid level, HbA1c, smoking status, exercise tolerance, and all these conditions. We have to follow up the patient to evaluate the patient to find if there is any red flag and continue the patient's management. These are high yield testing points for chronic coronary syndrome. A patient, an uh, older patient, like in 60, 65, something like that. The patient has risk factors like diabetes, smoking, maybe. And the patient develops substernal pressure while walking uphill or while exertion, maybe shoveling. Symptoms relieve within 5 minutes of rest. ECG normal, troponin negative. So this is a typical case of stable angina. When we see the ECG is normal, it doesn't mean that it's not coronary artery disease, because in many patients, the ECG at first it can be normal. If the troponin is negative, it doesn't mean it's not ischemia. It means it's not necrosis. So in transit ischemia, we will not see troponins because there is no necrosis, but ischemia is present. We do not advise the patient immediate PCI for every patient, for every chest pain patient. The management should be guideline directed and based on the risks, based on the diagnosis we come up with. PCI or revascularization is for refractory symptom, for high risk anatomy, for prognostic benefit. In questions, they will say, what's the next step? If there in the question stem, it's typical exertional symptoms, the patient can exercise, and there is an interpretable ECG. The next step will be stress ECG, exercise stress ECG, or CT angiography, if the patient can exercise. If the patient cannot exercise, then we do pharmacologic stress testing. For example, the patient is given a dobutamine. If the ECG is uninterpretable, ECG has non-specific changes, then we do stress imaging. If there are persistent symptoms despite therapy, the patient needs coronary angiography. Coronary angiography is invasive test. We reserve this for the high-risk patients. If we suspect left main disease, of left main coronary artery disease, then invasive angiography, which is coronary angiography. If the patient has wrist pain, we have to evaluate the patient for acute coronary syndrome. This is not chronic coronary syndrome, because in chronic coronary syndrome, the patient has pain only while exertion, and the patient is pain-free when resting. This was the review of our topics today. We will take a 10 minutes break, and after that we will start practicing the questions. I'll come back in 10 minutes.